Hello, my name is Jessica Fellinger, and this is my mini case study. Some of the personal information in this case study has been altered to protect the identity and privacy of the patient. This patient, Jane Doe, is a 67-year-old female. She's 5'7" and presents at 81 kilograms for a BMI of 29.5. She presents to the hospital complaining of altered mental status and decreased responsiveness. Her past medical history includes diabetes, hypertension, and a thyroid problem. Her past surgical medical history includes 2 surgeries for breast growths and eye surgery. She was diagnosed at this hospital stay with hypercalcemia, altered mental status, as well as aspiration risk. Some of the initial procedures include intubation and central line placement. The patient was initially placed on 20 mL per hour Glucerna with 100 milliliter fluid flush hourly due to elevated sodium levels. She was placed on a ventilator with propofol, which provides lipids. The NFPE shows mild to moderate muscle depletion in the clavicles, temporalis, and scapula. Her shoulders appear normal. She has edema in her upper and lower extremities. And her current admission weight was 81 kilograms. Her weight history from November was 93 kilograms, and from February was 90.7 kilograms. So this is equivalent to a 12 kilogram weight loss or a 13% total body weight loss in the last 3 months. Her estimated calorie needs are 1,400 to 1,650 calories per day, calculated by using the Eyreton-Jones equation for 81 kilograms of actual body weight. Her estimated protein needs are 64 to 81 grams of protein per day, and her fluid needs were calculated by 1 milliliter fluid per kilocalorie, so her fluid needs are 1,400 to 1,650 milliliters of fluid per day. She is on the ventilator and receiving 520 kilocalories from propofol, and her Glucerna initially was running at 20 milliliters per hour, and that provides 720 kilocalories for a total with the propofol of 1,240 kilocalories, 40 grams of protein, 360 milliliters of fluid, in addition to the 2,400 fluid flush, which was high because of her high sodium levels. Her nutrition diagnosis is moderate protein-calorie malnutrition, and the PES statement says that she has moderate acute disease or injury-related malnutrition related to recent hospital stay with poor PO intake, poor PO and altered mentation at the nursing home, possible aspiration pneumonia as evidenced by medical record, nursing report observation, 13% weight loss in less than 3 months, as well as mild to moderate muscle depletion in the clavicles and edema to the bilateral upper and lower extremities. So the nutrition intervention is to transition feeding to vital HP because the patient is on a ventilator, and the fluid is to be managed by the physician. Recommend minimum fluid flush of at least 30 mL per hour. Her kilocal needs from vital HP, the goal rate was calculated to be 35 milliliters per hour, which provides 840 kilocalories plus the 520 kilocalories from propofol, for a total of 1360 calories, 74 grams of protein, 840 milligrams of milliliters of fluid, and the 100 milliliter per hour fluid flush for 3240 total fluid. The goal after her initial nutrition assessment was that her nutrient intake needs would be over 75% of her estimated kilocalorie and protein needs in 24 to 48 hours, and that she would tolerate enteral feeding at the goal rate throughout her length of stay. So the first update later, the patient was extubated, but the Dobhoff tube was left in place. The patient received ice chips and water, but she choked on the water and was determined to be an aspiration risk. She was still on the vital HP at 20 mL an hour with 50 mL an hour fluid flush. So the intervention then was to increase feedings from 20 milliliters to 35 milliliters per hour goal rate of vital HP, with keeping the 50 milliliter per hour fluid flush. And then if the patient continues to tolerate the feedings, but still need the enteral feedings, we should transfer the feedings to Jevity 1.5 because the patient is now off the ventilator. The second update includes an evaluation from the speech-language pathologist. The patient was seen by the speech and language pathologist, who determined that the patient should remain NPO with the Dobhoff in place for enteral feeding, and that she will be evaluated again by the speech and language pathologist for a swallow study. The patient is on vital HP at 30 mL per hour with 100 milliliter per hour fluid flush. So the new PES statement is that the patient has swallowing difficulty related to recent extubation as evidenced by SLP report and nursing report. So the patient was having difficult swallowing because her muscles had been weakened due to being intubated for so long and then being extubated, so the patient still was appropriate for enteral feedings. The updated goal was to transition to Jevity 1.5 because the patient now is off the ventilator at 40 milliliters per hour, providing 1440 kilocalories, 61 grams of protein, 729 milliliters of free fluid. This meets 75% of the estimated nutrient needs. And that is the updated goal for this patient. This patient is also likely to continue treatment at a local rehab center, and that is the current update for this patient.